I want you to move from overwhelmed by information to confident in what really matters. I want to help you move from being unsure towards direction and purpose in your healthcare. I want to introduce you to health experts. I want to let you in on tough conversations on women's health. I want to give you a place where you can lean in and learn how to take care of yourself. Let's transform your health. Let's get clear on your goals. This is Women's Health Unplugged. I'm your host, Dr. Jordan Robertson, naturopathic doctor. Welcome to another episode of Women's Health Unplugged. I'm excited to share the stage today with my good friend, Dr. Kim Bretz. Kim, thanks for joining me again on the show.
Absolutely. I'm so happy to be chatting today. It's an exciting topic for me.
You know, you and I did a podcast episode together about 2 years ago on IBS. We talked about sort of diet restriction with respect to digestion and just how common that is as a go-to prescription for integrative practitioners, and really all of the damage that does, like psychologically and also to people's nutrition when we cut back food in the name of health. And I actually still refer to that episode often and share that episode for my patients to listen to. So if this is your first time tuning in to Dr. Kim, I highly recommend that you go back and listen to that last episode that we did together. It was such a good one. Today, we have a totally different topic on deck, though. And I wanted to talk a little bit about probiotics. We want to talk about gut symptoms, constipation, SIBO. We're going to cover a lot of ground. Kim, why is this an area that you are so interested in advocating for, like, patients for? Because I think that's when we come down to it. I think that's what we're really trying to accomplish today, is to help patients feel like they understand what their symptoms are, but also how to understand how to get help for it, because there's so much misleading crap out there. No pun intended.
I think that's one of the biggest things, is that in this area, we have so much research. It's such an exciting area to be in, but it's also an area that's been extrapolated a lot. And so whether it's ideas around constipation or SIBO or probiotics, all the things we're going to touch on today, there's a lot of misconceptions and myths and things that people have just done because we said we were supposed to do this, or it's something that we have these little ideas that because a probiotic in a study on a tissue could do this, therefore we extrapolate it into these very giant areas, or because something that we originally did worked, maybe, then we all need to do it. And that's really, really wrong in this area. And I find for a lot of patients, what ends up happening is they can spend a lot of money, whether it's on programs or supplements or testing, that they're just not going down the right direction. There's something that's being missed, or things are being assumed so quickly that it's something that's more of a gut catastrophic thing. And they're not getting better a lot of the time. And that's just so frustrating to me.
Yeah, it's interesting. I always used to shy away from treating gastrointestinal health in my practice. And part of it's because I felt like there was so much, like it was so chronic that, using the tools that I had maybe left school with, which we'll talk about maybe later, that I could help people feel better, but only like momentarily. And then we would end up kind of back where we had started. Or when I met patients, they had seen multiple practitioners and tried a million things and yet still had these chronic symptoms. And I think that speaks volumes to us really not understanding and identifying what's going on with people in the first place. Because if you've tried things over and over again and you're still bloated or still constipated, then we're obviously not getting to the root of the problem.
Very much. Yes.
So I want to pick on one thing that you said there before we jump into talking about probiotics, and you use that word extrapolate. And I think, like, as a layperson listening to information, right, and health information, I think sometimes we forget, to ask ourselves the question, like, how relevant the research or the finding or the thing that we're listening to is to us as, like, full human beings with like complex systems and organs and hormones. And what I mean by that is that sometimes we'll see benefits in like a test tube or in a rat. And that can sometimes get presented to the public as if it's like a solid fact of something that we should do in like an adult full human being. Is that what you mean by extrapolate?
Yeah, yes. So definitely that's one of the areas that I see a huge amount. I mean, that's within almost any area within natural healthcare products. But even things like the idea that someone has leaky gut syndrome and wanting to go down this pathway of, well, I must have leaky gut syndrome. We're probably it may or may not be the thing that's the issue if it's even happening in the first place. And then there's these whole treatment programs that will be set up around this sort of vague notion of leaky gut syndrome, where we're extrapolating into something extremely big that may or may not be the issue in the first place. And if it's happening, it's probably due to something else. And we're kind of fixing the downstream issue. We kind of see it in another way a lot of the time when we look at even something like cholesterol or bone mass density, where we're trying to fix a surrogate marker. When we really care about, did you have a heart attack or did you have your bone fracture? It's kind of the same with gut health. If we try to fix leaky gut syndrome, but your symptoms don't get better, do we really care? So we just make things very big a lot of the time, when I think we need to care about how you actually feel. Can you eat food? Do you have to be worried about where the washroom is all the time? Are people going to be asking you if you're pregnant and you're really bloated? Those are the things that we care about on a day-to-day basis. But we just turn it into these other really broad areas. And I think in gut health, it's set up to do that really, really easily, when that's not necessarily where we want to be going.
Yeah, I think one of the challenges with gut health is that we can't see it, right? Like,
Yeah.
like we kind of almost imagine things working on like this cellular level, which they're like, when you talk about leaky gut, I'm like, yeah, like we're basing entire treatment plans around like whether or not we feel like the tight junctions between cells have integrity, right? Like where there's not that many other areas of the body where we've taken it down to such like micro minutia. I don't know. I just find that whole thing so interesting.
Yeah.
But you're right. It like lends itself to these, like we're us painting like with like broad strokes against patients' symptoms. And partly because the testing has been a little bit wishy-washy, which I definitely want to get into. But before we go there, I just want to talk about probiotics because I have questions about it. Questions that I get asked all the time by patients, and I feel like I give them the most long-winded, ridiculous answer. And so I feel like you're a better person to ask, but like, should everybody be taking a probiotic? Can we go back to like just the root basics about that? Does everyone need a probiotic?
So personally, I don't think so. Now, I deal with a tremendous amount of gut patients, and there's usually going to be a point where we are dealing with probiotics, although often not for the reason that people think we're going to be using it. But it is something that there's points in time where I have people taking probiotics, but for me, the goal is really to be having a diet that's going to support your microbiota or your microbiome, all those bacteria that live in and on us. And we don't really have the evidence that shows that people are going to do better by having a probiotic on a day-to-day basis. And if we're doing that, what specifically that probiotic would be. Now, on the other hand, if you're independently wealthy and want to be taking a probiotic every day, if you're doing one that has good safety studies behind it, we probably haven't seen that it's harmful, but we're also not really seeing that it's helpful. And when we look at the idea that we have 40 trillion microbial cells that live inside of us, and most of those in the gut, taking a probiotic that has 10 billion in there is a drop in the bucket. It's not doing kind of, I think, the magical work that we've kind of ascribed to it a lot of the time.
Yeah, I think when we originally thought about probiotics, or at least the way I originally thought about probiotics, is that it was going to like replace and overhaul our gut microbiome, right? And then I feel like learning the fact that we carry around like 3 to 4 pounds of bacteria on our body, I'm just like, wait a minute, I'm not.
Yeah.
100% certain that this very small capsule that you're taking daily is even having a remote impact on any of that.
Yeah. And I mean, we see in some things, if someone's taken an antibiotic, taking a probiotic, and it actually can be almost anything from what we understand, can limit the risk for antibiotic associated diarrhea. So we have certain things that we generally understand that it can do. But we also want to keep in mind that those probiotics that we're taking, from almost every single study that we can see out there, they're not all of a sudden deciding that I'm going to take up and live in this person right now. The way that I tend to think about probiotics is that they're more like tourists. They're not immigrants. So they'll affect the environment while they're there. But if we test you a week after you stop taking probiotics, we don't find those ones any longer inside of you. So they're not continuing to do anything. They're just kind of helping out in certain areas of the gut for a while, and then they're gone.
I really like that analogy. I feel like it helps explain it quite well, because where that probiotic research is kind of moving to is that, rather than them taking up camp or, becoming the dominant population, is that they're actually maybe having some more like unique actions, each of those bacteria, right? Is that that's kind of where it's moving?
Yep. So that's what we tend to see. And some of it may just be after you've had antibiotics and you're taking a probiotic, they're just competitively inhibiting other bad things from settling into those open spots right now. So it doesn't have to be that they're even making anything amazing, but we do see that if they're there and they're bacteria that eat things and then they make a chemical like butyrate that we think overall tends to be anti-inflammatory, they might be able to help out a little bit with that. But again, we're not able to get in that many compared to what we already have. So the impact is going to be fairly low that we have. Doesn't mean it's not doing anything, but it's not doing sort of the miraculous thing that we thought. And then they're not going to stay indefinitely. They only have the impact, kind of like when you're on holidays. You impact the town that you're in while you're there. And then when you're gone, you're no longer using services and things, you're just gone. So that's the way I think about probiotics.
I love that we're still going on the tourist
Oh,
analogy.
I know. I know. It makes sense to me. It works in my brain.
And so when you think about, when you see conversations about probiotics being had, like whether that's like in online or whether that's even with our colleagues, like, do you feel like we're overblowing the benefit of them in general?
A lot of the time, yes. And I think even in the areas, and I do recommend probiotics, it's not that I don't. Most commonly, I'm going to recommend what they call strain specific probiotics, ones that have been shown to be beneficial in a certain condition in well-designed studies. Even then, the effects tend to be fairly small. So I think a lot of the time I'm having this conversation with my patients around what is the expectation that we have for this? Because if we've already dealt with, at least in part, a lot of your symptom, you're not all of a sudden going to be getting this extra ginormous magnitude of benefit from taking the probiotic. And a lot of the time what happens, and I mean, I've spoken for a lot of companies before, so I'm very comfortable with understanding what companies want us to be talking about, but we're getting information a lot of the time from companies that are just listing 8,000 benefits of what this probiotic could possibly do. And then sometimes that's being translated to patients in ways that just are not actually going to happen for the vast majority of people.
It's funny because I find probiotics to be one of the most commonly self-prescribed supplements that people are already taking when they arrive at the office. And when, I
100%.
imagine, yeah, like when I imagine like what's like, people are like, oh, and I take my vitamin C and I take my vitamin D, oh, and then a probiotic.
Yeah.
And when I ask them like, well, what's the like, why, like, what's the benefit? Their response is usually because I've heard it's good, right?
Mhm.
Like it's been almost framed as this like multivitamin status supplement that everybody needs and that provides this like blanket benefit. And I really would love to change that conversation, because feel like it does two things. One, when we want to shift to a strain specific probiotic, patients are surprised, right? I'm like, I need you to take this one. It
Yeah.
matters. Choose this one. Then they're like, well, I couldn't find it. Or like it almost dilutes the benefit of the ones we do know that have benefit.
Absolutely. And I actually just had someone within the last month, and we were talking about probiotics and what I had recommended. And she had asked if I could look at the probiotics that she had. And I'm pretty sure she had 12 different probiotics. None of them were specific for anything, which is always challenging. But the other challenge is, I think that a lot of companies and a lot of products that are out there, they want to have that value add to it. So when we're looking at individuals who have bloating or IBS, constipation, SIBO, any of those sorts of things, having a probiotic that has a prebiotic in it, so things that are going to feed the bacteria, often actually worsen people. So when we were going through both the medicinal and non-medicinal ingredients, there was almost nothing that even was well, this one hasn't been shown to do anything, but it's not going to aggravate you probiotic, which was really disappointing. That would have been hundreds and hundreds and hundreds of dollars worth of stuff that wasn't working. And that's really sad.
Because when I was going to say that other side there, like it's hard to get patients to switch to one that's strain specific. But the other thing is when I am recommending a probiotic that is specific, usually that person has dabbled with some kind of probiotic in the past and saw no benefit.
Yes.
And so then they're wary of, they're like, oh, I tried probiotics. Right.
Yes.
And it didn't work. And I mean, even sometimes in the research, we do probiotics a bit of a disservice by going like, yeah, you know what, we've looked at 1,000 studies on 1,000 different strains, and on average, they don't work. I think that we run the risk of patients also underestimating the value of probiotics in specific conditions when their history of them have been like that multivitamin kind of use. And nobody knows if they're taking a multivitamin, like nobody feels any better.
No, not at all. And it's not the same, but to me, it kind of has that flavor of, if you're iron deficient and decide to take a multivitamin, it's probably not going to help you. The effect, if there happens to be iron in there in the first place, is going to be so dilute, it doesn't matter at all. So if we need to be giving you something specifically, and you've just done this broad spectrum multivitamin of probiotics sort of idea, of course you don't feel anything. It doesn't even make sense in that world. But we've kind of decided that all good bacteria are all magical unicorns of goodness. And that's just not the reality of what we see.
That's the quote we're going to pull for this episode. Absolutely. So let's talk a little bit about bacterial overgrowth, because again, I think that term SIBO, I like that term leaky gut, like some of these catchphrases have kind of infiltrated into people's even identity of how they understand their gut. Patients often feel like they have gut overgrowth, or they feel like they have candida overgrowth, or they feel like something's wrong with them because they have these digestive symptoms. And one of our goals, and so you do some work for us in the Confident Clinician as one of our experts, and have spoken and are going to be speaking about some of the challenges we have with testing for gut patients, some of the challenges we have in managing conditions like constipation. But where's the research living with SIBO right now?
So this is one of the most exciting topics for me, is when we get to look at where we went wrong and how we can improve upon things. And SIBO is 100% one of these areas. So we have so many myths and misunderstandings within this, and that really, it affects a lot of populations, but our constipation patients especially, it's such a huge area within this. But basically, we had kind of this paper that came out in 2004, and it seems to be a really exciting paper that a lot of people cannot turn their brains off of. But what it indicated was that if someone had IBS, they had an 84% likelihood of having SIBO. And this was based on the idea that a lot of people with IBS have bloating and gas. And now we fast forward almost 2 decades later. And that, first of all, has been really debunked at this point. The rates of individuals who have IBS and also have SIBO is going to be higher than people who don't have IBS at all or gut issues at all, but it's nowhere near this 84%. We've also learned that the way that we've been testing for a really long time, so using lactulose testing has actually been something that has been recommended, that practitioners are no longer doing this anymore based on huge amounts of evidence. And one of the main things that we're actually seeing with that is with that lactulose, people drink this lactulose or glucose, but we'll talk about lactulose right now. And then that lactulose feeds bacteria in the gut, and then it produces hydrogen and methane. And those are coming from the bacteria. So if we see this really big rise that happens in the amount of hydrogen and methane being produced, that is supposed to mean that someone has SIBO. But what we've actually seen is that lactulose speeds up the time that it takes things to get from your mouth to your large colon. And we're actually measuring what is happening in the large colon. So in a lot of cases, this idea that someone has SIBO is not actually SIBO. We're getting what's called a false positive, saying that someone has a condition when they don't. And that's a main reason that we don't think lactulose testing is very good at all. We cannot differentiate between people who have IBS and people who don't. And we're measuring what's happening in the large colon where there's tons of bacteria.
So given like the consequences of that diagnosis, I mean, one of the things in medicine, I mean, I think we forget and patients often don't realize that every time you do a test, you have the potential of getting a negative test, but you actually have the condition, right? Which would be like a false negative. But sometimes we'll grab patients and flag them as having a disease or condition when they don't. No test is 100% accurate. We're always kind of walking this line of, did we grab anybody incorrectly, or did we, not diagnose people incorrectly? But there's consequences of a false positive.
Very much. And especially in SIBO, because what tends to happen is that, first of all, the first goal that people have is to kill this overgrowth. We're thinking that there's too many bacteria in the small intestine overall, and then we have to kill them. So if that isn't actually true, you don't have too many bacteria in the small intestine, we're killing inappropriately. And one of the things that I hear from practitioners in the consults that I do with them is, why isn't this patient getting better? Why does this keep happening over and over and over again? And a lot of times we actually have to look back and say, did we diagnose the right person in the first place? Did they have the right test? Did they meet the actual criteria to have SIBO? And that's not just having IBS generally, but also once the kill off has happened, then the next stages come in where people are usually getting a lot of supplements to help with motility, but they're also doing extremely restrictive diets. And I know this is what we had talked about previously, that often when we're doing things for patients with gut issues that are going on, we often are looking at some dietary changes. But when there's restrictions and eliminations, we need to have this exit strategy. And if we're not working with someone who has an exit strategy, there's something that's wrong going on there. But when we look at it from the perspective of SIBO, with SIBO, the restrictions are not just around what we would be feeding in the large colon. So we would think about a low FODMAP diet, but we're taking away a lot of the simple carbohydrates from the small intestine as well. So all of a sudden, when we're looking at individuals with small intestinal bowel overgrowth and IBS, we usually have that gut-brain side of things going on where we have more risk around depression and anxiety and disordered eating. And we can be taking people further down this really dangerous pathway.
Okay, I'm just going to say what you just said again in a different way, just to make sure that I got it, but also that our audience got it. So our patients with IBS are already at risk for anxiety and disordered eating.
Correct.
Now we have falsely flagged them as having SIBO because we didn't use the right test. Or we made an assumption. I will see in practice that lots of practitioners are making an assumption about bacterial overgrowth, but we'll get to that in a second. Then we're putting patients on a protocol that includes inappropriately killing, which now might be my new favorite phrase, inappropriate killing, which was your term, bacteria, and putting patients on a restrictive diet. They're not going to get better. And we've also reinforced their anxiety and disordered eating as a consequence.
Absolutely. That is the perfect way of putting it. Yeah.
Which, like, what a disaster, really.
It truly is something that it's so hard when you look at this. And I mean, I've been doing this for a very long time and reading the research for a very long time. And it's something that I think we have to be fluid within health, especially within the gut microbiota and gut health, because it's such a new area. We're constantly learning. And if we get stuck in our old patterns, we can just continue working with these myths and misconceptions over and over again. But I think because of social media and the way that things can work, it can feel like we have to go down this pathway. And I, as a practitioner, have become more conscious about this. I can see where I've gone wrong in the past with this and really have to be so cautious about what we're doing with diet and patients. It's absolutely paramount to people's health, I think, is to be able to have food and to be able to have that social connection. And and just we are taking that away from people when we are incorrectly diagnosing someone, when we haven't even figured out who is the right person to test. It's sad.
Yeah, it's really sad. And it brings up so much because you're right. Like, it's funny when it's trying to think of like, how can a person almost critically appraise the practitioner they're about to see, right? So we use the term critical appraisal to talk about, like, if you read the research and decide whether or not it's accurate or not. But even like to figure out who to see to support your gut symptoms is not an easy task for patients. Like, what would you suggest when you're if you were like a person in the public and had questions about your gut health or how to be supported, or you had just downright symptoms? Like, how do you go about finding someone that's not going to steer you down this SIBO path?
And I think, unfortunately, there's not a great answer with this at this point. I mean, asking where people are getting their education, their continuing education from. But I think in this case, sometimes patients are going to have to be aware of things themselves, because sometimes, again, as practitioners, we can get so ingrained in what we've done and saying, well, it worked well enough that I'm going to continue doing it. But I think patients understanding the fact, if their practitioners talking about lactulose testing when they need glucose testing, that's going to be a really big red flag. Just the idea that someone has bloating and gas and IBS should not be indicative of that you just do random testing at that point. What we need to say is that actually diarrhea is the most predictive symptom that we understand at this point. It's kind of funny to think about because bacteria make gases. That's often what they do. When they eat the things that they eat, they produce gas. But we actually understand that a lot of people who have bloating and gas associated with gastrointestinal disorders actually don't produce more gas than other individuals do. Sometimes they do, but sometimes the gas is just trapped and it's not able to leave. So we would often think about that in a constipated patient. That could be more likely. It's also something that patients who have, or individuals who have irritable bowel syndrome or SIBO in general, have more visceral hypersensitivity. So they feel things more acutely, but it doesn't mean that they necessarily have more actual gas being produced. So that idea that if you have bloating and gas, it's more likely that you have SIBO is actually just false. So if people are hearing that idea, that's going to be really incorrect. And then it's talking to the practitioner potentially ahead of time. But if it's coming up as a thing, why has the small intestine slowed down in the first place? Why is it that bacteria are able to overgrow? And those are some pretty specific things that are happening. So, certain medications make that more likely. If you've had abdominal surgery, if people don't have enough acid in their stomach, which again is not just a random suggestion because someone thinks you do, you actually don't have enough acid in your stomach. Chronic pancreatitis, there's different reasons that that can happen. But I think a lot of times what happens with practitioners is they think someone has SIBO because they have IBS and bloating. They do a lactulose test, they get a positive test, and then they reverse engineer it. And they try to come up with this idea of, why did the slowdown happen? When again, it didn't likely happen in the first place. So it's very challenging with this to kind of figure out who a good practitioner is, but you're going to want to look at, do they actually understand the updated research? Because right now, the research that is out there is very concrete. This is not something that is ambiguous at this point. It is very concrete that if someone's doing lactulose testing, it really is the wrong test to be doing.
I think that's such a good point. And I think even as a practitioner who's listening, because we certainly have a large practitioner listenership for the podcast, you know, if you find yourself saying, well, I learned this and it's more than 2 years ago, we probably need an update. And I would say that's probably true for most areas of research and areas of medicine, right? If people are treating PMS from, research that we had from 5 years ago, I would also say that they're probably not doing it correctly, or we're probably making some mistakes. And that's supposed to be the beauty of being in medicine, is that things get to change all the time. Yes. I think with the gut, because, it's an area of medicine, and hormones, I think, are subject to this as well. It's an area of medicine that has never really received the kind of attention that it deserves. And we've underestimated the impact of diet and lifestyle in conventional care. And that breeds this like opportunistic conversation in integrative medicine to be like, well, conventional medicine doesn't care about digestion, and I do. And it breeds these like kind of theories emerging, because it's at one point in time that was kind of all we had. Right? It's Absolutely. Like we put everybody on a gluten-free diet and lots of people felt better. And then we latched onto that as like, well, gluten must be inflammatory and gluten must be causing neurological symptoms in people and gluten must be this. And it's like we created the reason why people were feeling better, when we now like know why some people would maybe feel better on a low gluten diet. Do you know what I'm saying?
Absolutely, when gluten isn't actually the problem.
Right.
And we kind of want to be sticking with what we learned. It's hard to change our mind on things. And it's this whole thing around the lactulose studies is actually something that was very difficult for me, because what happened was everyone used lactulose. So it wasn't that I was doing a huge amount of SIBO testing. I think there's appropriate people to test in, and absolutely we're going to look at it in that scenario. But I wasn't doing huge amounts of it because I don't believe that everyone has SIBO. It's just not something that makes sense, both within how human bodies work, but also within the literature. It doesn't make sense to me. But when I was testing, I was doing lactulose testing. And then I started seeing the information about glucose testing being better. But what I was hearing was we were getting a lot of false positives within lactulose testing. And also saying that someone had it when they didn't have it, but in glucose testing, you were getting a lot of false negatives. So we were missing all these people. So then I started hedging my bets and saying, maybe you should get both tests done. But if I had really looked carefully at the literature at that point, I think I should have known even more than 5 years ago, about 5 years ago, that glucose testing was the direction, that was the correct direction. So then all of a sudden, when I started seeing it, that it was really clear, and we've had a bunch of meta-analyses where they pooled together a whole lot of data that came out in 2020. And up until now, we keep getting these pooled data that comes together that is just so clear that it's glucose, that there's just no way that I can, in any sort of good conscience, recommend that lactulose testing is a good option for people. But it hurts when you realize that you were doing something wrong. It doesn't feel good to look back and think, I did that disservice. And I don't think we're doing it intentionally unless you're listening to this information and you keep going and you don't look at the evidence and why it might be a problem. But I don't think most people are doing it truly as I want to be diagnosing people incorrectly. But we just get stuck down these pathways and we hear this information from individuals that we respect and the big names, and practitioners are the same as everyone. Like, we just get stuck in certain things, and it's so easy for that to happen. But it was very hard when I started looking and realizing that, oh shit, like, I'm really doing this. I should not be doing it the way that I had been doing it.
But that's what makes such a good practitioner, right? When you have that ability to pivot and learn with new information and change your daily practice. It's funny, we did a big hormone workshop a couple of weeks ago for practitioners, and I had previously recorded like a mini training on hormone replacement therapy for practitioners, and said something in that recording about where we sat with the information on cognitive decline and menopause, and that I was excited about the literature and where that could go as far as preventing dementia. And then in the updated version of the course, my colleague, or our colleague, Dr. Cara Denisio, was like, yeah, the research is not that exciting. We don't really think that it's going to help prevent cognitive decline. And someone put their hand up and they're like, but Jordan said. And we kind of just all had to sit in that for a minute. And I was like, yeah, you know what? When I recorded that like 18 months ago, it was kind of exciting. And we did think that maybe we were going to see some benefits for cognitive decline. And now the research that's, 18 months later is not quite as positive. We still are sitting in the huge gray with what we think we should do with that particular recommendation, but it's maybe not as good as what I said 18 months ago. And so even something that I recorded is kind of out of date. And I also have had to pivot the way I think about that particular recommendation. And we're doing that in medicine all the time, or at least we should be. But you're right. Like, it's hard when we have this kind of confirmation bias, especially in the industry where, you keep seeing things online about probiotics and SIBO, and it can really, and it does that for patients too. It reinforces ideas that, because we're way more likely to believe something we already believe than we are to change our mind about something.
Well, I did a talk on SIBO for practitioners last week, and it was really exciting for me to do it. It was also one of the most nervous that I felt for doing a presentation, where I knew that I was saying something that most practitioners weren't doing. And the good thing is I'm very confident to show the evidence as to why. So we were able to have a very clear conversation about that, especially with these lactulose studies where we're saying that lactulose isn't correct, where we're seeing that if we test using lactulose with individuals who don't have any gut symptoms at all, we were seeing that somewhere between 8 and 85% of people were being diagnosed with SIBO based on that testing. In some of the studies, we actually had more people diagnosed with SIBO who did not have any gut symptoms than the individuals who had IBS. We know there's a problem. We know that speed up in the transit time is an issue. And again, I was mentioning the constipation patients before, but it's kind of this weird thing when we think about constipation patients, because those are individuals who stool's not moving out of the body in the way that we want to. So things are just kind of staying there for extended periods of time. So now if we know that we're testing what's happening in the large colon, we're just testing huge amounts of hydrogen and methane in these people. And individuals with constipation get so frustrated because they're often feeling like they get treated, it helps for a tiny little bit, and then they revert backwards. And then they're just thinking it has to be SIBO. My symptoms, I have the bloating. And the 2004 study said that bloating is the main symptom. And my practitioner is telling me this, and then we test, and then it says it's positive. And then we just keep getting stuck over and over and over again because we're not actually treating the right thing. And that's so, so common in constipation. I think in some ways it's much easier to treat IBS, loose stool, or diarrhea type than it is to treat chronic constipation or IBS constipation type.
Now, you've got an exciting opportunity for clinicians coming up where we're hosting you doing a course on constipation. And I said to you, like, 6 months ago when we decided to do this, I was like, you can do whatever you want. I was like, you're the expert on gut health. And you chose constipation, which I don't know if that surprised me or not, because I didn't have a lot of expectations around what you were going to choose. But why this? Like, why do you feel like clinicians need advanced training on how to work with constipation?
Because I think that constipation is so poorly managed. It's something that there technically is a lot of information that's out there, but it's not put together in a very usable way. It's something that there's so many misconceptions around. Well, first of all, the whole idea about SIBO, like we're just we're not even getting to the root of the problem. We're just making up another problem a lot of the time. But things around food and fiber and how we understand that, we're still using the information that we had from decades ago that doesn't even make sense because it wasn't looking at anything through the lens of the bacteria that live in our gut. We didn't understand food in that way. But we're also having this misconception that using laxatives is helpful. And I mean, technically, it probably is helpful in the sense that it may be moving things through. But if we as a profession, whether that's naturopaths or anyone who's working in this area of gut health in general, are believing that taking laxatives is actually solving the constipation problem, that the underlying issue is you didn't have enough laxatives, that's really not what is happening right now. And it's just such an area that there's so much updated information that as much as I realize it's not a sexy topic, and I completely, when I look at this as who wants to listen to this, I recognize that I'm slightly crazy about this, but it's just such a topic that I see so many patients in my office who are, and again, pun actually intended, are so stuck that it just needs to be an area that we are better about as a profession, that we understand this, that we understand that if your patient is taking magnesium, they're probably still constipated. We can't even diagnose constipation if people are taking the herbs or the Restorelax or the magnesium or the things that are the laxatives. If they're doing that, we can't even diagnose them in the first place. So we've got so much confusion that's happening in this area. It is a very weird obsession for me, but I think it's a really important topic.
No, I love that you chose it. And even when I think back to my own challenges in practice over the last 10 years, or it's longer than 10 years, but I always say 10 years.
Yeah.
Where I have struggled is with patients with that chronic constipation that don't ever seem to get better no matter what we do. And I feel like, what I've been missing is the tools to be able to properly assess them, to be able to do the things beyond magnesium, right? I'm saying that in air quotes because you're right. Like we often as practitioners are just turning towards what we would consider to be a better solution for like motility and for constipation, when really we're not doing that much different than adding a laxative when we use magnesium. And for patients who are listening, if you're using magnesium every day to have a bowel movement, you got to share that with your practitioner because you are using an osmotic laxative to support your bowel health. And there may be more going on there or more that needs to be looked into. But I thought, that's a great question that practitioners can kind of reflect on and ask themselves about whether or not they needed this course is like, how long is it taking for your constipation patients to get better, or are they even getting better? Or are we just, kind of slapping some vitamin C and magnesium oxide, on there and then calling that a cure? I think that this is an area that we should be the expert in as integrative practitioners, nutritionists, naturopathic doctors. Like, really, we have such an opportunity because we are willing to talk to patients for so long about their food and their fiber and all of these things. But we need to know the solutions that are not just here, take this. Because otherwise we're not really doing that much better than the patient, like going to the pharmacy and grabbing a stool softener off the shelf.
And I think that's a big part of this, is that I think it's something that often we can become critical of, sort of this Western medicine model in a lot of things, that we're more integrative. We look at the whole person. And when it comes to constipation, magnesium is basically the same as taking Restorelax. Senna and Cascara and herbs like that are basically the same stimulant laxative that Daucolax is. Taking it that people's fiber levels are fine because they eat a lot of salad is wrong. Like, it's just, those statements are not helping people get anywhere in what's happening. And if we're not looking at this through the lens of the microbiota and how we understand, like, even things like, and I know that nobody in the audience is going to care about this other than me and hopefully some practitioners, but what is stool actually made up of? What happens if it's not moving out of the body? How do all of these things fit together within what medications people are getting, how it's working, the gut-brain connection, the SIBO side of things? Is it hypothyroid? Is it, like, all of those questions? Why is it more common in women? Are just not being addressed at this point in most cases. And that's something that is a disservice to patients.
Well, this episode just happens to be airing during the week that we have our early bird special on to join your course, Kim, which we put all the links for that in the show notes. And so if you're a practitioner who's listening and you found yourself going like, but I do give probiotics to everybody, or but I am using magnesium for constipation, or this is really going to be that advanced training that you need to feel a lot more confident in supporting those patients. And we definitely have some like walk away with resources that you can plug and play right into your clinical practice. And that's really the goal of all the work that we do with the Confident Clinician, is that we're saving practitioners time, but also giving them access to experts like Kim, who are giving us that up-to-date information, because nobody is quite as passionate about stool as Kim. And so who better for us to learn from? Kim, thank you so much for spending time with us on the podcast today. I feel like this was a really helpful episode for our listeners to hear some of those myths in gut medicine, but also for our practitioners to know that we've got some exciting things coming down the pipes for them. Do you have any parting words or anything that you want to leave our listeners with to be sure that they kind of took away from today's episode?
Yeah, absolutely. I think it's something that for all the individuals who are out there and have issues with gut health, it is something that this is an area that is so exciting. We have so much information that's come out recently, and so much of it is actually evidence-based, usable information that I think can really be transformative in people's health if they're willing to sort of look at things just a little bit differently at this point. Sometimes take a step back and not think that everything is maybe super complicated. I actually think this is an area that both for individuals with gut issues and practitioners, this is a terribly, terribly exciting time. I'm just very, very hopeful for this as an area.
Amazing. Thanks so much for spending time with us today, Kim, and all of Kim's contact information for her clinical practice, which is in Ontario, as well as our upcoming courses are in the show notes. So make sure that you click on them. Okay. Thanks, Kim.
Thank you. You have a great day.
I hope you enjoyed that episode of Women's Health Unplugged. My goal is to help you feel more confident about your health. Please remember that what we talked about today in the podcast does not constitute medical advice, nor was a doctor-patient relationship formed. If you have questions about your healthcare or about how today's topic pertains to you, please take it up with your family doctor, your specialist, or someone on your health team.